Good evening. So we talked a little bit already about some conservative treatment of superficial venous insufficiency. So just to recap it briefly for you, it really is elevation plus compression plus or minus NSAIDs for comfort. Patients will tell us, and we have studies that show that there is an improvement in pain and edema and overall well-being with that conservative treatment. However, there's no evidence of prevention of disease, and there's no evidence of prevention of recurrence or progression of disease. So that's really where intervention comes in. Either open or intravenous surgery can come in. There's a twofold recurrence in ulceration in patients who do not have superficial venous insufficiency treated. This treatment, conservative treatment, is also limited in patients who have arterial insufficiency because, as Dr. Welch actually alluded to earlier, you can't compress those patients significantly. The compression that we're talking about oftentimes will prescribe socks that are 20 to 30 millimeters of mercury, but in a patient who's standing, it actually takes at least 30 to 40 millimeters of mercury to compress the vein sufficiently, and patients often can't tolerate that. Next slide. So we alluded a little bit to open surgery. Overall, we do not typically do open surgery for superficial venous insufficiency any longer. This image is a postoperative result for a patient who had a high ligation of the great saphenous vein and a stripping. You can see sort of the unfortunate, complications that come from that. It used to be certainly standard of care, but we do have some now endovenous therapies that we employ. So endovenous surgery overall can be categorized into two groups. So either requiring tumescence, which is an anesthetic solution which is infiltrated around the vein, or those that are not requiring tumescence. So I'll go over both of those. So radiofrequency ablation is one that requires tumescence. The overall procedure is performed very similarly to the laser therapy. So I'll just briefly go over the steps for you. So step one, you can see that there's a sheath already here. What's pictured is the great saphenous vein. So it's a percutaneous treatment. The sheath is placed, and then the catheter, the radiofrequency catheter, is placed through the sheath up to the furthest point of treatment. So in the great saphenous vein, it's approximately 3 centimeters prior to the saphenofemoral junction. The next step, which any patient who has had this procedure can tell you, and any interventionalist who has performed this procedure can tell you, this is the most uncomfortable part of the procedure. This is the application of the tumescence. So under ultrasound guidance, we are actually infiltrating via a needle a solution of lidocaine and bicarbonate to hopefully make that more comfortable for the patient. So all along the catheter, all along the vein that is to be treated. The third step is the actual treatment. So this is where the radiofrequency ablation actually differs from the laser therapy. The tip of the radiofrequency ablation catheter typically is 7 centimeters. So you treat a 7 centimeter segment at a time. And the radiofrequency ablation, the treatment time is about 20 seconds per segment. And then you withdraw 7 centimeters and then treat that next segment. What's different in the laser therapy is that it's a constant withdrawal of the catheter as opposed to any segment that's treated each 20 seconds or so. And the fourth step is really the fibrosis and or the thrombosis of that vein, which leaves the superficial vein, again in this case the great saphenous vein, closed, allowing the patient to get their venous return through the deep system. So radiofrequency ablation results are pretty similar overall to laser therapy results, and they're quite successful. So the long-term closure rate is at least 90%. There are some studies where the closure rate is a bit less. There are certainly some studies where the closure rate is a bit more, and this is long-term, meaning at least a year. Some studies go out to 5 years, and there are still some studies that are, of course, ongoing. Minor complications include pain, hematoma, paresthesias. There are some patients who will actually have a result that looks a little bit similar to someone who had a high ligation and a stripping. They'll have that ecchymosis and bruising, perhaps a bit of a hematoma. That's mostly from the tumescence, which we'll talk a little bit about. Rarely, there will be an actual non-occlusion of the vein, meaning that the therapy did not work. That happens less than 5% of the time overall. Further out, there can be recanalization of the vein, so from centrally to peripherally, that vein essentially opens up. And if the patients continue to have symptoms at that time, then they might require additional treatment. The major complication of treating superficial venous insufficiency is a DVT. This is the rare complication, but of course it's the most major. Typically less than 1%, but there are studies, or there's one study that showed up to 16%. That's a clear outlier. Mostly it's less than 1%, up to 2% in most studies. Patients who do have a DVT, it's typically at that saphenofemoral junction. Those DVTs are classified and treated with anticoagulation, at least until the DVT has been shown to resolve. So moving into therapy that does not require tumescence, sclerotherapy. This is injection directly into a spider vein or perhaps the varicose vein, so the trunk perhaps of the great saphenous vein of a sclerosant. So one of the previous slides listed some of the sclerosants. The one that's most commonly used is polydocanol, which we'll talk a little bit about. There's a trial, the ESAF trial in 2008, which showed that there's a 69% elimination of reflux. So this is a treatment of the main superficial vein as opposed to a spider vein with a 3% polydocanol foam. And in this trial, there were no adverse events. So there were no patients with any DVT, et cetera. Sclerotherapy, like some of the other therapies that we're going to discuss, are poorly covered by insurance providers, so that is a downfall. So Varia Thena is, again, another polydocanol. This is a pre-foamed. It's a 1% as opposed to the ESAF trial, which used a 3%. This study called Vanish, Vanish 1 was the initial treatment of a superficial vein. Vanish 2 was the second or additional treatment of a superficial vein with the foamed polydocanol. This was actually carried out in 2013, so you can see that the results improved. Perhaps the technique improved, the sclerosant has improved, so that there was an 80% response of a resolution of reflux in Vanish 1, and 86% response or resolution of reflux in Vanish 2 with the foamed polydocanol. And then just to touch base a little bit on the quality of improvement, Dr. Welch also alluded a little bit earlier to this, and in Vanish they looked at the VV-SIMQ to assess the patient's quality of life improvements, asking them how much certain symptoms bother them throughout the day, such as heaviness, aching, swelling, etc. So there are 5 categories, so the maximum result would be 5, meaning the worst result would be 5. So you can see in Vanish 1, after 1 treatment of Varia Thena, the score improved, essentially 4.87. In Vanish 2, it actually improved over 5, if you can imagine that, seeing as the maximum score was 5. So the things that are a bit on the horizon are sort of touted as possible painless surgery. What is key about these is that, similar to sclerotherapy, they do not require tumescence. So the first, the trade name is Venocil, and it's essentially a surgical glue. So it's cyanoacrylate glue. The procedure is again percutaneous. It's again performed under ultrasound guidance, but it does not require any tumescence. And the glue is then infiltrated into the vein, allowing again that fibrosis and thrombosis. This is now FDA approved and becoming available in the US. It's available in Europe currently. Studies have shown that patients are, their quality of life improves more quickly. They have good results without compression, whereas I should say in radiofrequency ablation and laser therapy, we ask our patients to wear their compression stockings for 1 to 2 weeks afterwards. These techniques tout themselves again in not having to use compression afterward. The Venous study that allowed it to gain its FDA approval showed some minor DVTs. However, they were much smaller than is typical, and they actually resolved without any anticoagulation. Claravane is a mechanical occlusion and chemical ablation, and there are things that are similar to Claravane when they're essentially using a balloon or something, again, mechanical that's inside the vein. Claravane is essentially a wire that is rotating within the vein in addition to infusing a sclerosant. Similarly, it's been shown to require less compression afterward, to result in fewer DVTs afterward, and to go along with a better quality of life. One thing I should mention is oftentimes with percutaneous access of the vein, there can be injury to the saphenous nerve. It's been less reported in these, particularly in Claravane. So again, the proposed improvements of these techniques are that it's no thermal injury because these treatments are non-thermal. There's no tumescence, and that tends to be the least comfortable part of the procedure for patients. There's a lower risk of nerve injury and a lower risk of DVT. So this is, again, just to remind us, varicose veins, of course, come with discomfort. Again, the heaviness, aching, swelling, itching, etc. But as we've talked about earlier, what's most troubling about superficial venous insufficiency is that it leads to chronic ulceration. And this is a patient who had superficial venous insufficiency treated with radiofrequency ablation. This was the ulceration to start, and this is the healing ulceration. And again, more than just bringing that ulcer to heal, it's the prevention of recurrence.